So the first step, even before you even do any tapering, is it's important to get the patient's sort of acceptance. Now, they may not be happy about it. That doesn't mean they're gonna agree with you, but you have to essentially get them to a place where they're willing to go along with it. This is very difficult, really, for anyone to deal with. Even if you have some addiction training, it's difficult because patients will insist that it's being used for their pain and it's a crucial reason they're using it, and having them get the insight that they're also abusing their meds can be quite difficult.
Are you doing screening for substance use? Are you doing screening for mental health disorders? Are you doing screening as well for pain and for functional assessment? And doing all this screening at the outset lets you sort of frame what it is that you're doing together in managing their pain. So what the expectations are. So understand that the expectation isn't resolution of pain, but it's doing what we can do to better and best manage the patient's pain while also looking for functional improvement. And that we really do need to see both in order to warrant the risks of these medications. So in order to find out whether or not a patient needs to be tapered, the PDMP is a crucial bit of that information, and I would say that it's a part of your comprehensive pain management. And when you have that information, you can just present it to the patient. And so the key is to have an understanding of what the process is and why, to follow through on that process. So a patient understands that they're not singled out. This is the process that you do and you literally do for everyone. Patients understand that. And they feel better about that, because if they feel like that this is something that you've decided to do specifically for them, then they feel defensive, and that closes them off, and that really has a deleterious effect on the patient-provider relationship and your ability to take care of their chronic pain. It's critical to be completely transparent about what the tapering protocol is, and to describe that with the patient, and to come to a decision about tapering as much as possible together. So that if you're managing a patient with chronic pain and you decide to taper and there aren't significant concerns, again, for substance misuse, then it could be a slow taper. And you decide together what that slow taper would be. It could be a very slow taper, as long as you're following the patient closely. But again, the key is that you come to that decision together.
Yeah, so I had a patient last week who had transferred their care to me from a different pain specialist. And this patient had been on opioids at high doses for a long period of time. And it really was a scenario where it was unclear how it was benefiting them at this point. And so I had a long discussion about why they would need to go down. Very hard discussion, because the patient could understand why her previous pain physician kept her on those doses. And what we agreed to do is that we weren't going to taper at that first visit. I made an agreement that, okay, you come in next month and we'll start to go down. And in the meanwhile, I'll start some other non-opioid medications at a low dose. They may or may not help, but we'll do that. And I'll stick by you, I keep trying different things, in the context of going down very, very slowly. So I bring that up because that was a situation in which just having the discussion was actually the treatment that was done during the visit. The actual tapering wouldn't even start for another month. When you taper slowly, there really isn't any physical withdrawal. And it's really, again, psychological withdrawal, that the patients feel more pain, they may feel more anxious and jittery, they may have some sleep problems, some insomnia, but there really isn't true physical withdrawal, because there's enough opioid on board to prevent many of the physical withdrawal symptoms, such as, diarrhea, sweating, any of the autonomic nervous system withdrawal effects you see, such as increased heart rate. There's a lot of issues of psychological withdrawal in between doses that isn't recognized. So patients often say, oh, the opioids are benefiting me because if I go several hours without a dose, or if I skip a dose or miss a dose, for some reasons, I get more pain. And then when I take, the medication, the pain goes away, for temporarily. And really getting patients to see that, well, that's reflective of some degree of tolerance. That's reflective of some degree of psychological withdrawal. It's not really physical withdrawal, but it's a sense that your pain is getting worse and you're feeling a little more anxious about getting pain medicine again. That reinforces the idea the opioids are helping, when actually it's not reflective of the benefits of the opioids. It's reflective of actually the difficulties of taking opioids chronically. So that's often a tricky conversation to have with patients about tolerance and psychological withdrawal.
They're afraid of what they might feel, or if they're on a certain dose for a while, they know how they feel when they've, let's say, taken a few extra medications and had to go for a couple of days without, and they've experienced withdrawal symptoms. So they want to avoid that. But it's our role to have them understand that oftentimes that's not what we're not talking about is management of pain, we're talking about management of withdrawal in that case.